Right, we're getting some thumbs up, so hopefully we'll keep this connection now. Fingers crossed. So yeah, we'll start again from scratch. I don't think we're talking to ourselves this time. Thanks everybody for joining us. We are basically going to try and do some of these live Facebook feeds if Facebook is working appropriately during the sort of the coronavirus outbreak, but also following it. It's something we've been thinking about doing for a little while. We just wanted to try and put out a bit more educational content, but also our own personal experiences of what we've been through in terms of using ultrasound in our practice as physios, but also through our teaching, the different areas that we meet people from who work in different areas using ultrasound as well. So hopefully you find it useful. This is our first attempt. We have failed once already this evening. Dave's had a shave freshly for it, so hopefully this will all work appropriately this evening. A little bit about the ultrasound site for those of you who are new to what we do. We run a number of musculoskeletal ultrasound training courses, including injection courses, predominantly in London. We also work with Brunel University around the PG Cert case accredited program. And we also have quite a vibrant presence on social media, but this is certainly the first time that we've done a live feed. So just to start with, I think it'd be useful to probably introduce ourselves individually. So if I could maybe hand over to you, Dave, to start us off with that one.
Yeah, okay. So yeah, I'm Dave Baker. I'm an advanced practice physio. I've worked in MSK for about 20 years, sort of 17 years NHS, specialised in MSK. Been using ultrasounds in sort of day-to-day practice probably for about 12, 13 years, doing sort of mixed MSK list, and use ultrasounds sort of every day for diagnostics, but also ultrasound guided procedures. I teach on a few various sort of postgraduate programs, and I'm chairman of ACPOMIT, which is the professional network for physios interested in injection therapy. And I have a role for a specialist advisor on the interventional procedures program with NICE, and do a lot of teaching obviously with these guys for all things ultrasound, and physio prescriber as well. So sort of involved with anything to do with injections, prescribing, and ultrasound really is pretty much me.
Yeah. Great, Dave. Thanks. I'll follow you, but yeah. It's going to be hard to follow in this man's footsteps, I think. But anyway, so yeah. So for me, like Dave, I am still working full time now in the NHS. I used to work with Dave, and obviously I'm still working with Stuart. I've been ESP for about 15 years. I've done ultrasound for about 12 years. It's an integrated part of my my clinical role, my advanced practice role. Where I use ultrasound as an extension. I'm an independent prescriber as well, which kind of is helpful also for the injection part of ultrasound. In terms of other areas that I work in radiology as well, 1 day a week, where I do a sort of mixed diagnostic and also interventional list. In addition to that, I do some private ultrasound guided injections. And obviously for the rest of it, I'm mostly working on educational resources, such as the stuff that you can see through the ultrasound side, and also the weekend courses, and in the last year, of course, the Brunel postgraduate certificate, which is what we're really enthusiastic about, and which we feel is a great sort of course for people starting out on more formal training routes.
Cool.
Yeah, that's me.
A lot of what these guys already said involves what I do as well. Surprise, surprise. Ultrasound machines only exist in certain domains or certain rooms, and we tend to operate in the same rooms. So I work as an APP physio in London, and 2 days a week. I also work as a consultant musculoskeletal sonographer 2 days a week as well in a radiology setting. So the radiology setting involves interventional work, but diagnostic work, and I guess the physio role is more of a point of care role as well. I also sit on a couple of committees within the UK around ultrasound education and injection therapy for the Chartered Society Physio, and also represent the CSP on a committee with CASE, which are an organisational body that oversee ultrasound education in the UK. And I'm sure we'll probably touch on the role of CASE going forwards tonight, hopefully. So just to start off with, I think it's always quite nice for us to sort of reflect back individually as well on our journeys of how we got into musculoskeletal ultrasound initially. When I think back, I sort of remember some of the challenges and the trials and tribulations of starting to use ultrasound in practice. And I think sometimes it's quite nice for people who are thinking about starting out on a journey around this kind of area of practice to listen to that experience and to maybe think about how they can adapt what they do at the moment to try and facilitate them learning and starting this area out. So Dave, I don't know if you want to start us off with thinking about how you started out with using MSK ultrasound and back in the day when you started training and everything else, and how you found it.
Yeah, I think probably, I think my first ever exposure to musculoskeletal ultrasound was actually probably about as far back as, must have been about 2004, something like that. I was working in a A&E injuries department, and there were one or two registrars there that had come over from other hospital where obviously ultrasound, musculoskeletal ultrasound was being used more. And they sort of kind of started to introduce it a little bit temporarily into our sort of injuries department. We're sending particularly shoulders, acute shoulder injuries around for ultrasound scan. It just always sort of sticks in my mind. And then sort of, you know, I think then the next sort of main point was John Leddy, who's a bit of a legend in MSK ultrasound, I'm sure we all know. He had a piece in the Frontline magazine, and he was just talking about how, you know, physiotherapy and ultrasound may, you know, be a sort of, you know, potential thing that could be brought together, skill set that could be brought together. And we were lucky enough, John came down and did a sort of introductory afternoon at the hospital where we worked. We were very, very fortunate to be able to purchase a machine for the department. I think it's sort of a, you know, everyone sort of played around with it and tinkered around with it for a few months initially. And just from there, I think, you know, I think there was always this kind of, you know, sense within physiotherapy that the tests that we had weren't particularly accurate, that physiotherapy could oftentimes be a bit vague, and just this idea that you could sort of actually look inside the person and, you know, maybe give a formal diagnosis or certainly tell people what was and what, just completely sort of fascinated me, as I'm sure it does the other people on the group and many people watching as well. Just completely fascinated me from the get-go. To me, that was just the, you know, why wouldn't we look inside somebody if we were able to?
Yeah.
I just want to come in there. I think in terms of why you would start to use MSK ultrasound in your practice, and I guess we're talking from a physio perspective here, but there'll be people watching from all sorts of different professional backgrounds. One of the key things was that I could actually see the things that I've been talking about, trying to feel and try to stress test, etc., for many, many years. And I could actually see it at the same time as assessing the patient. And that was a really powerful thing for me. And then the whole anatomy thing as well, I think was a real eye-opener compared to the textbooks as well.
Yeah, I think physiotherapy, I think Rob once said that physiotherapy is generally a very low-tech profession. And you sort of walk around the hospital and there's all these sort of like gadgets and machines and computers and everything like that. And you walk past the physio department, there was nothing. You know, there was maybe a sort of biofeedback machine or something if you were lucky. Yeah. Again, it sort of somehow to sort of lag behind with sort of technology and sort of 21st century, you know, capabilities. And it just never sort of really sat easy with me. And, you know, the fact that we just didn't seem to utilize any sort of, you know, technology in the same way that so many other departments were. So again, it really filled in a space that to me was sort of a bit of a slight sort of gap within our profession up until that point. And when I say physio, I mean throughout MSK, not just, you know, not just physiotherapy per se, but in sort of musculoskeletal sort of management person, you know, generally.
Yeah, totally. Well, you know, your journey in that respect was very similar to mine, because I believe that you actually organized that very first course where John was teaching at St. Leonard's. So, you know, thanks, Dave. Otherwise, I would never have got into it, because I was just not very interested. But after that, I actually became interested. Now, it wasn't like that, because, you know, like I do remember at that time there was some sort of like capital, a bit of money in the system to buy a big piece of equipment, and there was like a lot of talk about like, so how will we spend it, and what are we going to, you know, buy some I don't know, like some sort of, well, we weren't going to buy a traction machine anymore. They were actually, like you said, the high tech of the years gone by, as in like expensive machinery, was actually gone. So I think the only thing I could think of was a diagnostic ultrasound scanner. And once we'd done that ultrasound course, that was then done. And then we kind of started our journey and trying to actually get competent, because once you have a scanner sitting in your room, then you actually have to start using it. And then it became a little bit difficult, because you're not competent, you're not actually knowing what you're looking at. But we were very lucky, because informally we had, right from the start, some input from people like John Leddy, and we did some evening sessions where like-minded people all came together, and those were really good, and it sort of really stimulated my interest in the topic. Yeah. And then from then onwards, we started doing weekend courses, and we ended up then doing a formal route, postgraduate certificate, and that's what we all did. And you know, we still continue to learn. And yeah, at the moment, I'm working obviously with these guys through Brunel, and etc. And it's kind of an ongoing journey. I don't think we'll ever. I don't know what happens in the future, but I don't think we'll stop using ultrasound anytime soon.
Got to wait for Dave to regrow his beard and then shave it again, and we'll probably still be here chatting about the same things. Yeah. So in terms of training, you mentioned there, Rob, that, you know, I'm not going to sort of talk particularly about my journey. It's very similar to you guys, and I guess I came along a bit later in the day, so in some ways it was easier for me. And when people think about that access to support, and often I have conversations with people saying, look, I'm on my own. I haven't got that much peer support near me. I haven't got any colleagues who are scanning. I was in a very fortunate position when I started using ultrasound, or starting to learn about it and get an experience with it, that I had people in the rooms next door that I could go to and probably bombard them on a fairly regular basis when I had the scanner in my room. I mean, you think back as well about the frequency of how much contact you need to actually get going with this thing. I mean, the skill acquisition with ultrasound is challenging. It's a difficult skill to acquire, and you know, one of the difficulties is around machine access, isn't it? And trying to have that regular contact with the machine to actually learn that motor skill. And I remember I used to have it sort of half day a week, and you'd look forward to it. You'd get a hold of the machine, you'd start scanning. And then at the end of the session, sometimes I felt quite deflated, because it was difficult to actually see any improvement. You're scanning, you're not sure what you're seeing. It's difficult to move the probe around. It's a really difficult period to try and get through in terms of support, contact, and everything else. I don't know how you guys felt about it at that time as well when you were learning, because you didn't, I guess you probably didn't have the same degree of support that I had probably at that point.
No, mate, you had loads of support.
I had loads of
myself support. and others. Well, you know, like, yeah, it's very difficult, I think. I found it hard, and I'm just totally own up that in the beginning, you know, it was really tough going. You know, obviously my mentor, John Leddy, was my mentor. He was, you know, pretty critical of scanning. He was, you know, in a fair way, but like just basically to make sure that your technical ability is up to scratch. And you know, in those days, because we didn't have the sort of day-to-day supervision, because we got him and I think Rob Laus, who was the other person that supervises, we got them in, like, you know, once or twice a month or so, like a little bit more maybe, but not that much. And then we got them, these were quite intensive sessions, but, you know, it was very hard to to see the progress, because you kind of having to learn, and every time there's another aspect that you think you mastered, and then there's something else that you feel you can't do, and it's actually very frustrating. And I felt a little bit, particularly when it was about like 7 or 8 months, and I thought, well, when is it that I feel really comfortable and happy, and I can sort of recognize these structures, particularly pathology was quite difficult sometimes. But I think it was that difficulty, I think, and the fact that you persevere and you keep asking questions and you keep having some input, that eventually makes it a lot easier, because in the end you learn from those things. I think it's always a bit suspicious if people say, oh yeah, I've seen it a few times and I know what I'm doing and I'm fine, because that's not how ultrasound works. And everyone who has worked in ultrasound for a long time, and even people, I'm sure, like people who international, renowned sonographers will tell you that 10, 15 years in their journey, they're still learning new stuff every single day.
That's always the $1 million question, isn't it? Is I get an email from somebody saying, look, I want to get into ultrasound. How long is it going to take me to skill up and be good at doing ultrasound and have this conquered?
Yeah.
And that's a really difficult question to answer, I think, isn't it?
I mean, as Rob knows, I'm quite a renowned bass player. Now, I having learned a musical instrument, I oftentimes say to people that are learning ultrasound, and it's by far the sort of closest thing that I could ever relate it to. It is like learning a musical instrument, because there's so many different sort of aspect to it in terms of a skill. There's the sort of motor skill side of it, there's the sort of cognitive side of it, there's all these different, and we'll obviously probably talk about some of this again later on in the talk today, but it's sort of a combination of lots and lots of different skills. Some you will find sort of easy and natural. So some people might be better at the sort of motor, sort of disassociation, looking at the screen. Some people may have a better understanding of anatomy to begin with. Some people may be more sort of like technologically minded, so are easier to get to grips with the whole sort of physics of the ultrasound machine. And then you've got your sort of clinical experience and all of these things, and you've got to somehow bring it all together in that moment, so that when you're performing an ultrasound, there's all these different skills and all these different things sort of feeding into one another. Yeah. And I think, if ever people, how I would sort of relate it to a musical instrument, and that is, if anyone sort of says, like, how do you get good at ultrasound? It's the same as with any practical skill. It's just practice. The number one thing is practice, followed by getting some sort of like good feedback, either from some mentoring or some sort of like peer support. Yes, look at your books. Yes, sort of go over your anatomy. But you can read a book for 1,000,000 years, it won't teach you how to do an ultrasound. It's a practical skill, and you have to, kind of just practice, get better at it, refine your technique. And I guess the other thing that you were saying about, you never get, every year that you're doing ultrasound, you look back on yourself and you think, oh, last year I was rubbish. Last year I didn't know what I was doing. So you actually become more self-critical. And I think it's that sort of classic sort of knowledge versus experience curve that you often see sort of talked about, isn't it? Where to begin with, and you start to think you know everything, and you think you're absolutely brilliant at scanning, or you start to think you've got it and you've nailed it, and then you actually realise that that you've got so much more to learn, and that to actually get really, really good, it's almost impossible to get really good at scanning every single sort of region simultaneously or whatever. So you get this realization that it's a lifelong thing, and that you will be forever refining your skills, and there'll be certain aspects of it that some people will have to put more time and effort into than another. And your point about people's expectations of how quickly they'll learn, I think we've had 1 or 2 people in the course saying, by the end of this weekend, I want to be able to scan a shoulder. And the equivalent I always say is like me going up to, or someone going to a piano teacher and saying, by next week, I want to be grade 8 on the piano. Yeah. It's not going to happen. Unless you're the next Mozart, you're not going to get to grade 8 in a week. You're not going to be able to scan a shoulder brilliantly in a weekend. So I think there's just lots of parallels there.
I totally agree. And, following on from your music talk, Dave, actually, I don't know if I've ever told you that I played the saxophone. Maybe I'll have to bring it along to a weekend course. We'll have a little duet one day. You didn't know that, I don't think. So that's made your night, I'm sure. I think you raised some really good points. I think one, if we're going to break down some of the challenges that people face when they start scanning, one of the big things that I found difficult was just orientating to the image. And I think when you come from a less traditional sort of setting in terms of imaging, getting that concept of the different planes of imaging, what you're looking at, all the different angles, is a real challenge. On top of the actual motor skill of using a probe and trying to keep it in the right position and not, letting one end of it drift off over there or whatever. The actual orientation to the different planes of what you're looking at for a structure is really tough. I found that very difficult, and the fact that you're looking at a grayscale image, again, can be quite baffling. It's just very alien. It's not like anything else that you would do in clinical practice until you start to encounter it. So those things I found really difficult, and particularly.
Yeah, that's interesting, because I was just this is an article that I read a little while ago, and that talks about the core psychomotor skills, and which is really interesting, because they're the motor skills, but also the interaction, obviously, with you driving it with the brain. And basically, it said one of the factors there was like translating 3D anatomy to a 2D image screen, and that's actually that processing that your brain has to do that is something that's quite significant, and that it's not something you think about easily, mostly when you first start doing it. But and also moving a transducer in multiple planes, and depicting the optimal image for any particular given scenario, because in one scenario you might have to use a different technique or in one type of patient, and with a certain body habitus, you might have to do very different things to achieve the same or a similar results, sort of thing. And that's quite interesting.
That's a really good point, Rob. Was that I think in terms of learning and trying to really, if you're trying to accelerate your learning around this, if you are doing teaching, it's a great way of learning more, because there's a pressure on you to develop content around something, and then you're really then hot on your image quality. Certainly I found that was a really sort of beneficial thing of being involved in education and teaching as part of the learning process. And I guess one other sort of key thing we sort of touched on there a little bit is almost this sort of separation, isn't there, between that learning that ability to scan a structure, as a core kind of technical skill. So see a ligament, just be able to get a good image of that ligament. And then even on top of that, you've then got the whole spectrum of pathology and how you're going to interpret that and how you're going to decision make around it and take the patient's care forwards as well. And I think they're two very distinctly different things. And I think when people sort of say, oh yeah, it's going to be a year of me, year of scanning, and I'll be up and running. I think there's still a huge learning curve that goes on after that. I'm sure we've all been on, and people out there hopefully agree on this as well, that learning curve continues on around pathology, the spectrum of pathology, what's normal, what's symptomatic pathology, what's asymptomatic pathology, or structural pathology. And that's one of those key things, isn't it, around ultrasound. I think we're getting more aware of, and it's actually a real benefit, I think, of having that integrated into what we do as clinicians as well.
Yeah, but you like what you're saying. It's like going from the anatomical scanning, which is what you're doing in the first couple of years predominantly to really get good at the basics, to recognizing pathology. And in simple pathology, you would probably recognize fairly rapidly. But like you have found, and I find every time in my radiology clinic, there's a lot of stuff out there that's completely, like sometimes completely, you're a bit gobsmacked when you get the kind of scenario in, and you think, Christ, I've never come across this. And I must have to sometimes look it up whilst you're sort of like in your clinic room to sort of, because you get some unusual clinical scenarios. And, that mileage that goes on, that's not something that's just going to stop. That will go on, and that needs time. So yeah, you always learn.
Dave, you're going to come in there. You look like you're about to.
No. I mean, I completely agree. I mean, in a way, it's interesting, isn't it? Because you know, what we're sort of saying is that actually, you know, they're almost sort of like different skills, aren't they? Or there's so many different sort of like aspects to it, because to actually perform the scan, to understand the anatomy, to recognize what you're looking at, and then to sort of almost then be able to, you know, put the sort of clinical reasoning around it and the clinical decision making around it. It's a really sort of almost like a multi sort of process, isn't it? And it's all happening, you know, simultaneously, and you can sort of start to understand, you know, the why it is, as we're saying, it's just like a never-ending sort of learning sort of curve. But I mean, you know, and again, that's what makes it so interesting to us all, isn't it? It's because...
No, absolutely. And I think, you know, we've mentioned there some of the challenging things about it. Were there bits about it that you found easier to pick up when you started scanning? Were the things that you know, you found generally a bit easier? You know, in terms of, I mean, I found, again, you know, maybe it is the kind of the musical kind of component. So I found holding the probe and manipulating the probe not too challenging. It's always a great practice thing, isn't it? That spinning on a structure. It's a nice thing that the guys out there who are watching, you know, if you find a structure, find a patella tendon, for example, go long, short on it. That handling of the probe is a great thing to pick up. I didn't find that too hard. I think I found the orientation stuff, as I said, I think I found that more difficult to try and get around. And I think the other thing from using ultrasound, if you like, in more of a point of care environment, that communication with the patient around the findings, around handling that dynamic around it. I think in the initial stages, you're building your confidence up with using the modality in that setting. It can be quite challenging, and can be quite difficult. As you become more confident with it, and your conclusions that you're making inevitably becomes a bit easier. But there's definitely a skill around that probably doesn't get the recognition as well that it deserves, probably, in terms of as being a key aspect of you know, of learning this skill and integrating it.
I mean, you certainly see it when people coming on the course, and I suppose that, as you say, if you reflect on yourself, there'll be people that come on the course and you can see that they have really good motor skills, or they just natural sort of like affinity for actually sort of like the handling the probe. And like you mentioned earlier, Stu, even just the really simple things like orientating themselves to what's going on the image. You know, occasionally you even have a patient who looks at the screen and they're like, oh, is that my, you know, and they sort of like almost just naturally seem to be able to sort of really understand what you're doing. And yet sometimes people just find that whole idea of the sort of the slice that the probe is like making and how it's forming the image just really difficult to sort of orientate in their mind. So, but then it's a journey, isn't it? We've all got strengths and weaknesses, and every bit of that journey, some of us find like easier or more difficult than others. And I guess it's being sort of like having that sort of reflective ability to sort of think, right, I know that that's not going to be my strong area, so I need to particularly practice that. Or looking at your professional background and thinking, well, okay, you know, I've already got these transferable skills to this, and therefore, you know, but this is something that I know I need to work on. I really like learning practical things, but I wouldn't say that I have a natural affinity to it. So I immediately know I'm going to have to really, really, really practice motor skill side of it and refining it. And it's just that, you know, if you kind of know that, I think from my physio training, I knew that, you know, I had to practice my manips a lot, and I had to practice every single aspect of anything that I did. But I love doing that. I love learning how to do little sort of, you know, things like that. So but yeah, everyone, you know, will sort of find different parts of it. And then I guess then it's knowing going back to sort of like what we were saying with the support and everything, like how do you then supplement the support for the things that you know that you need that are going to be sort of like particularly tricky for you. And that's something that again requires a bit of reflection, and hopefully
I personally felt that I found you know, the technical skills, of course they're difficult, but you know, I kind of that was something that I kind of managed at some stage, and not too hard. But I found that, like, for example, like, which I very vividly remember, like, you know, seeing someone with a obviously torn, now if I think back, supraspinatus tendon, and I kind of really didn't clock it, because there was like, you know, there was like, I don't know, like scarring and some sort of bulkiness of probably of the bursa overlying the humeral head. And because, you know, if you look at the grayscale of that, actually it wasn't a huge amount different from a tendinopathic tendon. So for me, it was almost sort of like saying, well, you know, I remember being in this whole debate with my mentor and saying, well, you know, surely how can you tell? Because, but I think, you know, like looking at it in now and looking at the three, like, you know, like putting it all together with your clinical hat on as well, I guess, because I just tried to sort of reason from the image. It kind of, you know, was, there were obvious telltale signs, but it was I remember that I wanted to read that grayscale almost as if you had a sort of a kind of, you know, a kind of chart where you say, okay, black is like torn or dark fluid and bright, and I just wanted to kind of be more succinct and clear, and it wasn't like that. There wasn't a, you know, that, so that realization made me think, Jesus, it's more complex than I actually thought, you know. Like, yeah.
So. That's also a classic thing that you find, isn't it, that people want absolutes with things, and I think ultrasound. Certainly the grey scale, the spectrum of grey, you know, I won't go down the pun of the 50 Shades of Grey kind of comment, but it you know, that grey scale image doesn't give you those absolutes that you want when you're at a beginner level, and that makes it really challenging. I think we've also touched on there the sort of the dynamic nature of ultrasound, and how there's so many different pitfalls to the angle that you're scanning, the patient's position, and how that all impacts upon image quality as well. There's all those different elements that make it a challenging thing to start out with. I think it'd be good to move on to talking about training. And I know I can kind of summarize our training. We've all done a similar thing. We've all done a PG Cert, case accredited program in the UK. That's a university-based program that tends to involve taught face-to-face content, as we do now in the Brunel program that we provide with Brunel, but also that logbook, that mentoring side of it as well, which I know is often a significant barrier for people to try and get going with this as a new technique in their practice. I just wonder if it's worth me at this point just sort of sharing maybe an overview of how things are in the UK in terms of training routes. I don't know if you guys had anything else to add about that kind of first learning curve.
As long as you don't start playing your trumpet, Stu, I don't mind.
It's a saxophone, Dave. Come on. So if we just try and share this again, bear with us, guys, because this is all very, very new to us. Hopefully that works. I've got a few comments coming in here from Stu Kerr. Evening, Stu. Hope things are all right up in Scotland. Yeah, probe skills is difficult. Absolutely. Identifying areas to focus on in training, so each having our own individual requirements, I think is really important. And Matthew's over in Holland, I presume. Yeah, now he can't go to bed because he knows we're doing this. Sorry. we really do sleep, eat and drink ultrasound. So this is just a slide, hopefully, that you can all see that shows just a couple of different things really around MSK ultrasound. This is really for people who are new to this topic. In the UK in particular, we have a number of different sort of ways of training around CPD courses at weekends. There tend to be the more university-based or M-level programs with assessment components built in that are usually CASE accredited. So CASE is the Consortium for the Accredited Sonographic Education, which it's an organisation that oversees educational standards in the UK for ultrasound courses, not just MSK, all ultrasound disciplines. And they also offer accreditation of smaller focus courses around things such as maybe the hand or the foot. Then there's the self-directed route, and one of the big issues in the UK that we have around ultrasound is that ultrasound is not a protected modality, if you like, in terms of being a profession. A sonographer is not a protected title, as a number of other professions are in the UK, and so that does mean that it's quite open. and there are a number of different parent professions or professions who are using ultrasound in their practice, which you can see on the right here. So you can see there's a number of different professions now engaging ultrasound in and around the point of care environment in particular. The knock-on of that is that there's a number of now, I think, not conflicting, I wouldn't say, but there's a number of different training options that are out there in the UK landscape that are driven by that multidisciplinary landscape. So many different professions will be creating their own guidance documents about how they feel their members should be starting to train in ultrasound, using it appropriately in their practice and trying to develop competence ultimately. There's also obviously domains where it's utilised most traditionally, and the biggest amount of MSK ultrasound is still performed in radiology settings, predominantly by radiologists or sonographers. Most sonographers are radiographers by background, who then go on to specialise in musculoskeletal ultrasound as well. So that's where the most of it is still taking place, but there's this growing and evolving landscape, if you like, around the point of care environment. I wonder if it's worth us just at that point, just going back to a discussion around mentoring and the challenges that we found around that, and whether you guys have any thoughts about how people can try and tackle that in terms of creating peer networks. I know Stu up in Scotland and a few other people are trying to build networks of people around the country in the UK to try and support the growth of this in terms of mentoring and peer support, which for me is a really important thing going forwards.
Rob, do you want to start on that one?
I mean, we were lucky. We were lucky in that we had a group of people who could all support each other fairly frequently and fairly closely. We were also very lucky when we started training that we had really good support from radiology within our trust. So that paved the way, I think.
I mean, you know, well, peer support, I guess, working in the place that we worked, and we've touched on it on our initial journey. We were very lucky that we were having a lot of support in terms, you know, like ultrasound is not necessarily always something that a lot of people in a clinical setting, particularly managers, think necessarily is something that that's a core or is an important thing to an adjunct to physiotherapy. And I think, like, because we work in a fairly innovative place where people actually work a bit more broad-minded and open-minded to that, I think that made it easier, because once someone, and obviously I was the first person in our department to train formally, then you can sort of spread your skills, and I think you, Stu, benefited from that, because then of course you still had your mentorship, you know, in addition to my support, but you had that support as well. And I think once you have a little group of people that have been trained up in any kind of place, then the next step for the next generation of people coming through is a hell of a lot easier. So I think it's just that sort of getting that initial foothold where you have no links with radiology, you're kind of almost isolated, there is no known pathway. That was about 10 years ago. I think now situation is a little bit better, but you know, due to financial constraints, due to political issues between kind of the POCUS and the non-POCUS radiology settings and finance streams through hospitals, etc., it can still be really difficult. And in our courses, we hear that all the time. We always think that we're living in some sort of, you know, a very sort of positive bubble sometimes. You only realize when you actually see that other people find that journey a lot more challenging, and then you realize that actually no, that isn't always the case. But yeah, you have to be lucky, and I think you have to be quite creative and work hard at getting those skills. But
great question from Stuart Kerr, just coming on the Facebook page. So what advice would you give to those who experience some resistance to AHPs developing ultrasound skills and utilising it within their practice? Really good question, something that we commonly encounter. And I think probably overall, I like to think that it's the landscape is changing, that people are more recognising different professional skills, and as a result of that, people are more open to people developing skills around it. I think one big thing for me personally is the understanding of and the value of learning from radiology colleagues. I mean, I really have gained huge amounts from working in that environment. And if I think back to when I started scanning, my understanding of imaging and the different professions involved in imaging was pretty poor, I have to say, compared to now, where I understand all of the different professions that are involved in radiology, but also as a result of that, I understand the different imaging modalities so much better. That's probably a knock-on from ultrasound generally, but I understand the different imaging modalities and what you can see with different imaging modalities much better now than before. But in terms of how you overcome that resistance, I think that's about harboring relationships. I think it's about engaging people at an early stage. When we talk about mentoring, and I certainly would, if you're thinking about starting to utilize this in practice, that's one of the biggest things to start thinking about. It's like, okay, who can I tap into locally? Who can I build relationships with to try and get experience? Sit in clinics, take your time to sit in with people of an evening clinic, a weekend, just go and sit in their clinic and watch them scan. I remember sitting in with Rob and other colleagues when I was learning, and I had no idea what they were looking at, and I had absolutely no idea what they were talking about when I first started doing it. But you've got to put that time and invest that time in it, I think, to really start to get learning. And by doing that, you can build relationships, and hopefully, Stu, in terms of the question you sort of posed us there, that then facilitates people open up doors and open up gateways. And I think with time and with responsible use and standards and demonstrating good standards, that helps. I think going forwards.
Yeah. No, I agree. And, certainly working out in private practice, come across a lot of people that sort of, want to learn to do ultrasound, but, particularly in private practice, no one's going to come sort of like knocking on your door to train you. So you've got to think about, put yourself in the position of, you've got to be proactive. You've got to think about, maybe what skills that you have that may be sort of like useful to the other person. And so that you're giving as well as taking, in those sessions. And, you've got to be prepared to sort of go the extra mile sort of thing. It's not easy because there's lots of people, but also, be a good student, if you know what I mean. So there's nothing more disheartening if you have sort of agreed to start mentoring somebody, and that sounds really obvious, but they don't practice. So they come back the following week and they haven't moved on from where you last saw them, sort of thing. So be a good student, do your homework, and make it easy for them to train you.
that also then knocks it onto, doesn't it, the big issue, which is about machine access as well. And I know I don't want to sort of like run into our future sessions and stuff too much, but I know we're going to talk about machines and getting hold of machines. And again, when you start doing this, it's a difficult landscape to navigate, isn't it? Where do I even start trying to think about who provides machines? What machine do I need? What probe do I need? So we're going to thrash all that through with some extra expert panelists in a couple of weeks. But machine access is a big thing. You can't learn this without a machine.
No.
Sounds really obvious, but it's such a practical thing. You've got to have access to a machine. And you mentioned right from the outset, Dave, that frequency of access is really important. And we were lucky that we had, at the time, a very accessible scanner in our service. And we've been very, very fortunate in terms of the access to machines that we've had. But that's a really, really important thing. I'm just conscious of time, and it's approaching 10 o'clock. I think it'd be nice just to think about now. We've talked about training. We've talked about maybe some of the different routes in the UK, the fact that the landscape is reasonably open. There are certainly some excellent M-level courses, which are obviously unbiased, but we offer one through Brunel. The case overseeing the quality of those courses is excellent. There's also a number of weekend courses of which we provide, but also a number of other people provide excellent weekend musculoskeletal ultrasound courses as well. I guess once you've gone through that training and you're starting to use in your practice, is it worth it just sort of wrapping up this evening thinking about the key things that you think it's informed your practice? How's it impacted upon your practice? How's it changed your practice? I mean, one thing for me was I never went into it thinking I want to learn this skill so I could guide an injection. It wasn't even on my radar that I wanted to use ultrasound to guide injections. It came to me today thinking about that. I never at any point when I was learning was thinking about utilising it for injections and to guide injections. It was more about informing my management, informing my knowledge of what I could do with patients at that time. And I think it's impacted my practice in a number of different ways. I mean, certainly my anatomy is hugely improved. Certainly my knowledge of pathology is improved, and my knowledge of maybe normal structural pathology is improved. And I think that's improved with awareness and research as well, probably with time. Don't know what you guys think. Any particularly salient points?
Yeah, well, for me, I think.
Yeah, I mean,
you go, Dave. Yeah.
Traffic jam late in the evening.
Yeah. So I'll be quick, Rob. I was gonna say that you know, for me, it's, you know, said before, you know, it just seemed to me such a sort of obvious thing that in this day and age where we can sort of do all these other sort of crazy things, that if someone's coming in and they've got a shoulder pain or whatever, that, you know, if there's a way of, say, you know, refining our clinical assessment and adding more objectivity to it, then, you know, that's what I wanted to do. That's where I wanted to be at, sort of thing. You know, I wanted physio to be, or wanted musculoskeletal medicine to be more black and white, more factual, more objective. Now, I'm not saying that ultrasound necessarily, the interesting thing is it doesn't necessarily give you that, but it opens up this whole world. And as Stu was saying, you know, you realize that there is no black and white, and there is no, but by this time you're consumed in it anyway. And there's this whole sort of like chasing the whole sort of thing about, you know, we'll talk about, you know, pathology and relevance of structural and in later sort of webinars, but you then sort of take everything else down to sort of like nth degrees and seeing studies coming out now. There was one just going around today, I think, wasn't there, looking at sort of changes on deltoid, possibly predicting sort of like diabetes and things like that. And I just feel like there's this whole world of discovery still that ultrasound has got to offer us. And I feel that there is a whole world of discovery around issues like, you know, why is it that, you know, that pain and structure don't sort of like necessarily always tally, but you've got to see it and understand it and sort of integrate it into your mind, into your clinical practice, to really sort of start to even appreciate it more, sort of thing, isn't it? So it's that whole thing about the more you go into it, the more you realize we know nothing. And the more you realize just that it creates more questions than answers, but it's like the book you can't put down, sort of thing. You just constantly sort of chasing the book, but this must have some, you know, this must tell us something and all this sort of thing. So I'm just looking forward to my next 20 years of ultrasound scanning. I know that people look very different on ultrasound, but what do all those differences mean? Are we ever going to know? Are we ever going to make sense of it? Are we ever going to make sense of this whole structure versus pain thing? And getting back to, I guess, the clinical question that you said, Stu, is like a patient comes in and they want a diagnosis. I think there was a paper some year, you know, what are the 3 things that someone wants to know when they come in to see a doctor or a clinician or whatever? And number 1 is they want a diagnosis. They want to know it's not anything sinister, or that they want to know that it could be cured or whatever. They want to know if there is something they can do about it. And I think what ultrasound does do is it allows you to more fully answer those questions from the outset. I always found it incredibly underwhelming as a physio to say, well, we'll do this for a little while, and then if it doesn't get better, we might send you for an MRI scan, or we might say, you know, that to me just wasn't, I didn't go into a profession to do that. So it's all about the patient experience. It's about your developing knowledge and enjoyment in what you do, and sort of having this sort of almost like never-ending quest for sort of making sense out of what you're doing, and hopefully getting a few people better along the way.
Yeah. Rob, do you want to add anything?
Yeah, I mean, you know, I agree totally with what you're saying. It's that whole structure and the biopsychosocial versus the sort of more like mechanical structural thing. And you know, there are no easy answers, but you know, like I think sometimes the argument against ultrasound use is a little bit around like, well, you know, like we know that structure doesn't matter that much because there's a lot of studies that demonstrate that, you know, the neurophysiology is the sort of driving thing and it's not necessarily the structure. But I think, you know, like being like aware of anatomy, having in-depth knowledge of anatomy, which you have to have doing ultrasound, then having that layer of extra understanding to see all the sort of structures and be able to pinpoint very precisely that's an extra layer of information, like Dave said, and that paints the picture. All the different scales, you talk about gray scales, but it's never black and white, but you can layer that onto it. And I think that, you know, if that's utilized, obviously in an incorrect way, and people kind of make inferences that they shouldn't make, then it could maybe make things more difficult. But let's not like start from that premise. Like, you know, if we are good practitioners, we will be able to help people and sort of facilitate. And I think then it's just fantastic, and we see that day to day in our practice. So no, it's absolutely essential, I think, as an adjunct. Yeah. No.
Yeah, and I think hopefully in the coming weeks, what we've got planned, guys, is to try and do these, as mad as it sounds, try and do these weekly at 9 o'clock on a Thursday night. And the main reason for that was that's the only time that we could try and pin all three of us in front of a laptop with our busy work and family lives and commitments at the moment in what are quite challenging times. But hopefully we're going to have a schedule of things coming out that will not only, you know, there's discussions like this giving you an idea about training, but also will just flavour what you can see with ultrasound in particular next week. So covering some of the key structures that you can see, perhaps touch on areas of pathology. But then going forwards, as I've already mentioned, I can just see that Doug's actually joined us this evening. So evening, Doug. Doug's going to join us in a couple of weeks just to talk a bit more around machines, the devil in the detail about machines. It's a very, very challenging area, and we're very, very lucky to have his expertise coming along to join us in a couple of weeks' time around machine choices, probes, all of those kinds of things that are also difficult. And going on to talk about governance and lots of other different areas of practice as well within ultrasound. So hopefully you found this evening useful. Hopefully there's something in there that's that you've taken away from the last 45 minutes of us lot nattering, apart from me announcing that I played the saxophone in my past and Dave announcing that he played the guitar, or he still does play the guitar probably. But yeah, thanks very much for joining us. We're very, very grateful for the support for those of you who signed on tonight. Apologies for the glitch to start with, but we got there in the end. Hopefully next week will be a bit smoother, and we look forward to chatting about it with you over the next few days on social media, and put your questions in on Facebook and Twitter and everything else. So thanks very much from us, and we'll see you again 9 o'clock next Thursday with some more content to chat about. Cheers, guys.
Take care. Bye.